So I think a few more people maybe joining in a bit just after work, but just wanted to get started and just thank everyone for joining tonight. And I'm excited to introduce Alex, who has previously received the RAN Advocacy of the Year award and is currently serving on the YPS RadPac liaison. I'd like to thank Alex once again for taking time out of his busy schedule to speak with us tonight. So Alex, if you want to take over?
Yeah, sure. Thanks, Luke, for the introduction. Um, this is a topic that I have presented before, and I think we did a talk on this last year. And so tonight's talk will be a little bit background on this, a little introductory, and then also with some updates. And I know radiological advocacy or advocacy in general is not a topic that necessarily everybody thinks about, right? It's not super fun, it's not exciting, it's not sexy, but it's really vital to our profession as radiologists. And hopefully this talk will show that it can be crucial to both our patients, to advancing healthcare, and ultimately actually making real change that we can see the effects of every day. So, just a little background about why I am. Oh, sorry, slide difficulties. Okay. Background about why I can talk about this. So I'm an interventional and diagnostic radiologist at Robert Wood Johnson Barnabas Health over in Newark, New Jersey, but I'm a New York resident, so this is my home state society. I'm a board member of RadPac, which is the political action committee of the American College of Radiology, and then also a board member of the Radiology Advocacy Network. And then, like you mentioned, Luke, I'm currently serving as the YPS RadPac liaison as part of the ACR's YPS executive committee. So I've had some experience with this. So let's start by just talking about a few objectives of this presentation via these questions. So what are some current and future challenges to medicine and radiology? How do these future issues affect patients? How do these affect me, my practice, and the future of radiology? Do you have any ideas on how to change them or what to do about them? And then do you even know where to start? So let's start here. What is physician advocacy? So this definition was adopted from the AMA's definition of advocacy, and it's action by a physician to promote those social, economic, educational, political changes that ameliorate the suffering and threats to human health and well-being that he or she identifies through his or her professional work or expertise. So advocacy at its core is about helping people. The ACR kind of breaks it down into three pillars. So they sub-select it into representation, education, and support. So representing the interests of radiologists and their patients to Congress, state legislatures, regulatory agencies, educating radiologists in training and patients regarding legislative and regulatory developments, and then supporting grassroots participation in advocacy via Capitol Hill Days, legislative calls to action, the Radiology Advocacy Network, and RADPAC, which again is the political action committee of the ACR. So to add three more questions to this, why is this important to physicians? Why are physicians in turn important to advocacy? And then how can we get involved? There's a few different levels of advocacy that I like to talk about here. There's personal advocacy, which could be something like advocating for a new title at work or a salary boost. Patient level advocacy, making sure a patient gets the appropriate testing or doesn't get unnecessary testing. Practice level advocacy, such as advocating for reimbursement reform, because that's going to affect how your practice is able to survive. Community and systems level, so looking at insurance approvals for cancer screenings. State level, each state deals with issues like scope creep differently. And then, of course, there's national level advocacy, which can deal with sweeping policy changes, including AI or licensure. So how does it affect us as physicians? So it affects us as practicing physicians because the healthcare landscape is always changing. There's always introductions to different policies, new guidelines, new practice metrics to follow. There's always the threat of reimbursement cuts from Medicaid. So patients are always affected. The care that we give as physicians directly affects the patients that we're caring for. We are the arbiters of their care, but they're the recipients of these decisions that are often made out of their control and without their involvement. And then we're the next generation of change makers. The issues that are decided now may impact us for the next 20, 30, 40 years of our careers. So, what I want to do for a few minutes here is just go over some topics in advocacy, and each of these topics tends to have a few subtopics that fit into them as well. So this part can get a little dry. I'm aware we'll try to rush through this a bit, but so under the reimbursement pressures and payment reform, Medicare physician fee schedule cuts, year over year reductions that we're seeing, especially for imaging and procedural services, it threatens practice stability. I think every 6 months we see a call to action from the ACR, the Radiology Advocacy Network, that deals with writing to your congressperson, asking them not to cut reimbursement for radiology services. And we've been really successful in that, but we still have to deal with those reimbursement cuts year after year after year. There's RVU and CPT code changes, so shifts in RVUs and work RVUs directly affect productivity-based compensation, for example. It doesn't factor in things like complexity of a study rather than, just say you're reading a CT abdomen and pelvis. It doesn't factor in if this is a cancer follow-up or an ED study. It reimburses the exact same. And then there is site neutral payment reform. So there's always ongoing policy debates about equalizing payments across hospital, outpatient, for freestanding centers, and how this could reshape practice economics. So in IR, for instance, there's always a discussion about whether biopsies should be performed as inpatients or as outpatients. And while we like to talk about the safety concerns about doing biopsies as inpatients, it can't be understated that there is also a financial concern for the healthcare system, for the hospital, or for anybody doing the procedure as well. For workforce and scope of practice expansion, we deal with radiologist shortage. We hear about radiologist shortage all the time, especially with the growing imaging demand and physician burnout. And these workforce shortages are leading to heavier workloads for those of us that are in the workforce. It's harder to hire radiologists, but then again, it is good for people who are applying to jobs right now. So there's been a couple resident specific legislative policies that have been proposed in order to deal with this. There is something called the Resident Education Deferred Interest Act, or the READY Act, and this would basically allow resident physicians to defer their federal loan payments with no interest accruing during residency. So this would offer significant financial relief for them during training. There's also the Resident Physician Shortage Act, which it looked to expand the amount of residency slots throughout the whole country. It wasn't very significant. I think it was a total of 1,000 slots over the course of, or sorry, yeah, 1,000 slots over the course of 10 years. So it was like 200 extra slots. And that wasn't radiology specific either. There is the constant battle with mid-level expansion. So across the country, nurse practitioners and PAs are pushing for expanded imaging interpretation rates in many states. So by statute and practice standards, RAs can perform fluoroscopy in certain procedures under radiologist supervision, but can't actually issue independent diagnostic reports at this time. But there's always new legislation that's introduced that tries to kind of to roll the ball down the hill a little bit with this stuff. So some states, Texas, Tennessee, North Carolina, they've actually enacted licensure laws for RAs that define and limit their role, explicitly stating that the final image has to be read by a radiologist and it's their responsibility. But states all the time are, like I said, introducing new laws that look to counteract this. And then artificial intelligence, it's not just a technical tool from an advocacy standpoint. AI in radiology is less about whether AI can read images and more about who regulates, who pays for them, who owns the AI, and then who is accountable for these imaging decisions. For appropriate use and prior authorization and imaging access, there's always debates about prior authorization reform, and insurance companies and insurers are continually delaying or denying imaging through prior auth requirements. So advocacy works on pushing for streamlining and making this process more transparent if it sticks around at all, the prior authorization process. One that is especially relevant right now, as the most recent call to action from the American College of Radiology uh, dealt with this, is the ROOT Act, which deals with AUC reform. So it would aim to balance appropriateness with physician burden. The ROOT Act reforms the appropriate use criteria program by replacing CMS's complex imaging consultation mandate with a simpler, more physician-friendly process. So it eliminates the real-time claims reporting requirement and replaces it with a simpler, more provider attestation that basically says the AUC was consulted at the point of care. So this would help avoid disruptive IT integration and EMR workflow delays. And then compliance with this would be monitored via retrospective audits with the goal of informing provider education and utilization management rather than interrupting care. When it comes to patient access and equity, advocacy increasingly focuses on ensuring underserved populations have timely access to imaging. And I'll show a slide in a bit that touches on this, but there's been multiple policies that have come out that aim to improve this. So the Improving Seniors Timely Access to Care Act, which it aimed to allow for faster access to imaging studies when cancer or urgent diagnoses are suspected. There was colorectal cancer screening with CT colonography. There was low dose chest CT for lung cancer screening, and then increasing access in rural and underserved communities through things like I mentioned before, increased GME funding, but specifically for residents in underserved areas, and then also trying to deal with teleradiology reimbursement parity. So a lot of info on that one. When it comes to NIH funding, obviously a lot of imaging research depends heavily on federal biomedical research dollars. So budget cuts directly affect this type of innovation, and we saw that the most recent federal budget directly cut NIH funding, or it slashed it. The Trump's budget bill did the same. So there's a huge need for people to really stand up and show how decreased imaging research funding would negatively affect patients. And then there's radiology specific initiatives inside federal budgets, things like AI, theranostics, developing new imaging technologies. These all have to deal with the congressional budget. And then when it comes to quality, safety, and patient value-based care, so payers and CMS continue to shift away from the fee for service model, so getting paid for per scan or per procedure, and move towards the alternative or value-based models, such as getting paid for quality, getting paid for higher outcomes, getting paid for better efficiency, and then bundling payments together through DRGs or diagnosis related groups. So radiology groups might be measured on things like turnaround times, adherence to evidence-based imaging guidelines, patient safety, and then follow-up communication. These are all metrics that might be used to determine how much you actually get reimbursed for doing what you're doing. So it can be good for radiology. I'm not saying this is a bad thing, but it needs radiologist input into the constant evolution of these changes. And then these things all also highlight the move from the fee-for-service model towards E&M billing, which can be really difficult for radiology. Radiation safety and dose monitoring programs. Then I already talked about a little bit about cancer screening programs, lung cancer screening, CT colonography, breast cancer screening, breast density legislation, and then any new screening guidelines that pop up as well. And then just a couple more here. So when it comes to AI is obviously a very big topic right now, but there's a lot of questions that this brings up as well. Who's liable when AI misses a cancer, right? So radiologists must advocate for guardrails and common sense AI regulation laws. And then when it comes to patient data use as well, so there's going to be a point where there's a lot of AI research being done, and the research that is advancing the field might be done by AI. So we have to balance innovation with HIPAA and federal HIPAA laws and new state level privacy laws. So radiology, as we know, generates massive amounts of imaging data, and it's critical for advancing these technologies and AI tools and precision medicine. But we have to balance innovation with patient privacy protections. So these laws create a bit of uncertainty about how imaging data can be shared, how it can be de-identified, how it can be commercialized. Advocacy in radiology is mainly focused on, or partly focused at least, on ensuring that these policies protect patients' trust while still allowing responsible data use for things like research and AI development and clinical innovation. And then future reimbursement for AI. So, whether AI augments or it replaces tasks that we do right now, it's going to have huge impacts on our careers. You know, some people say it might even get to the point where instead of you reading a study, AI can take the images that are acquired and it can hone in on the pixels and it can compare those with the chart information and all available chart information from anybody that had a similar presentation and hone in on diagnosis. Who knows when or if it would ever get to that point, but it's important that radiologists have a say in this process. And then lastly here, we already talked on increasing GME funding, and then medical liability. So advocacy influences malpractice reform and state level tort changes, right? Radiologists are uniquely vulnerable to medical liability since, missed cancers on mammography or incidental findings not followed or delayed stroke diagnosis. These are some of the most litigated areas in all of medicine. And this risk obviously drives defensive medicine, where radiologists might over-recommend follow-up imaging studies to protect themselves. That in turn raises costs and patient anxiety. So radiology advocacy really deals with malpractice reform and state level tort changes to reduce frivolous lawsuits and create a fairer standard of liability with these, ensuring that radiologists can focus on patient care rather than practicing defensively. And this also relates to other areas of medicine that result in overordering of studies as well, which in turn overburdens radiology, such as the emergency department, as we see more and more utilization of the emergency department and independent practice by APPs. We see an increase in imaging studies that are ordered. So studies have shown that APPs who practice independently order far more unnecessary imaging studies, which, as I said, contributes to radiologist burnout and overburdening the system. And then lastly, physician wellness and burnout, or issues like call burden, RVU pressures, regulatory overload. These are all advocacy priorities. So, all right, now that we got through some of those current issues in advocacy, I just wanted to talk about a few issues that are specific to New York. So this is a screenshot from the Radiology Advocacy Network's website, or radiologyadvocacy.org. And you can go on there and I'll get into a little bit about how the utility of this website in a bit, but you can go on there, you can click on any individual state and it'll show you all the state level advocacy issues that are currently either up for debate in the Assembly in New York or the House in other states or the Senate. And then if you click on each individual bill or policy here, it'll take you to a little summary page of it. So I just want to go through a few of these, but with particular note that New York has one of the most numerous radiology specific or radiology adjacent bill counts in the country right now. And a lot of these are dealing with cancer screening mandates or certificate need, but they deal with artificial intelligence and scope practice creep. And there's a lot of breast health regulation as well. So okay, first one is New York Senate Bill 5657, the Interstate Medical Licensure Compact, which I think this would be welcome from a lot of us. But this bill would enact this Interstate Medical Licensure Compact in New York, which would create a more streamlined pathway for doctors who are licensed in multiple states to obtain or maintain their licensure in New York. So radiologists who already hold licenses in multiple states, or those who wanted to practice across state lines, such as teleradiologists or hospitals with regional networks that cross state lines, would benefit because the compact simplifies the licensure process and it reduces the administrative burden needed to obtain a New York license. It's this state medical license reciprocity has been something that we have been advocating for years and years, and I can't think of anybody that wouldn't want this necessarily. But it would also facilitate broader practice opportunities. So, say a New York radiologist could more easily cover imaging services for rural areas or cover overnight services in other compact states or vice versa. So, it could really increase the flexibility of practice models. On the flip side, radiology groups or practices in New York may face increased competition from out-of-state radiologists who can more easily gain licensure across the country. So radiologists would still need to maintain continuing medical education and credentialing requirements and comply with all of New York's medical regulation framework, but the administrative and licensure entry barrier would be a lot lower under this bill. The next one is New York Senate Bill 3265, which is the AI Bill of Rights. So this bill would create a new artificial intelligence Bill of Rights for New York that gives New York residents rights such as being informed when an AI-based decision system is used, having the ability to understand how and why the system made a decision or why it made that decision the way it did. It would give residents the right to opt out of fully automated decision making if they wanted to. And then it would ensure there's a human fallback whenever AI systems are used. So for radiologists, this reinforces the importance of maintaining human oversight of AI tools. This ensures that radiologists always have a hand in review of these algorithmic findings. And it has implications for liability, ensuring that the clinician oversight remains robust always. And for training, radiologists must understand how the AI works and its limitations and how to intervene when needed. And there are many states that are trying to adopt an AI Bill of Rights, and I think it'll get to the point where there's a federal AI Bill of Rights. But again, it's one of those things that if radiologists aren't involved in this, somebody who is not a radiologist and who's not involved in radiology or doesn't understand the specific concerns is going to be making these decisions for us. So the last state specific one I want to talk about is New York Senate Bill 580, the dense breast ultrasound bill. So this bill would amend the New York public health law, I think is 2404, so that when a radiologist notifies a patient that she has heterogeneously dense or extremely dense breast tissue, that notification is automatically considered a determination of medical necessity for the purposes of insurance company or insurance coverage, excuse me, for a subsequent breast ultrasound. So this would obviously simplify workflow and reduce insurance denial burden, but it would also likely increase the number of breast ultrasounds that are ordered, which could increase the demand for breast imaging services and resources, stretching imaging centers and radiologists thin, who are probably already very thin. Overall, this would support more proactive imaging for patients with dense breasts and hopefully save more lives through early detection, though. So, when I talk about advocacy, right, it sounds like this nebulous topic, and obviously there's people who are working across this all across the country. But why specifically do you matter? Why should you get involved in this when there's other people who can probably do this a lot better or may know a lot more about it? But radiology really is personal. Okay, or I'm sorry, advocacy in radiology it really is personal. You are the next generation of patient advocates. All of us are as young physicians. You are the resource for informing state and national bodies about local issues. So the ACR, they obviously are going to advocate for state level issues and local issues, but they need people in those states who are actually encountering these issues to tell them what's going on and help them understand it better. There's personal and institutional advocacy. So this focuses kind of how your institution can keep up with or be the innovators of national policy, but also how you can learn to advocate for yourself in order to accomplish something like your career goals. And then there's the establishment of a grassroots effort, which is making grassroots efforts in general are when you get a lot of people together and they as a whole or as a collective influence policy change because of that collective effort. So from a state level, different issues affect states differently. Members are vital to addressing these state issues, kind of like I was talking about with the ACR and how they need to know what's going on in each state. And then different states encounter issues differently. So an example of this is scope creep and how different states are dealing with independent practice of advanced practice providers. Some states allow it, some states don't allow it, some states kind of allow it. So each state is a little bit different. State leaders really do listen to you. They know that you are their constituents, and if they want to get elected again, they can't ignore a subset of their constituents. Um, so you do have a lot more influence to these people in state level positions than it may seem on the surface. So why don't physicians tend to get involved in advocacy? There's a lot of reasons. I think part of it is we have this long, intense training. It removes you from the community a bit, right? So you're not always acutely aware of the issues that are happening outside of your specific practice area. We get a lot of training in medicine to remove personal bias from these clinical encounters. And oftentimes, what's most effective when you're advocating is having a personal story or sharing a personal encounter. So we're kind of taught to not do that. And then we have to try to relearn that ability. there's a fear of conflict sometimes with in employing an institution's agenda. Your desires and your goals as a physician trying to help patients may not always be aligned with the goals of a hospital system or a private equity firm that may own part of a practice or own a hospital system. There is a conflict with evidence-based culture in the sense that we are taught in medicine and we subscribe to the belief that you should really only do things that are evidence-based. But a lot of advocacy, like I mentioned, is sharing personal encounters and personal stories. And there is a lot of overlap. For instance, the breast health screening and the cancer screening mandates and policy changes, those obviously are very evidence-based, but a lot of it are things that rely on emotional appeal. So, not wanting to make a splash, when we raise our voices and when we go advocate on Capitol Hill, for instance, obviously it can cause publicity sometimes. And as physicians, not everybody wants that. Not everybody wants to be in the spotlight. You want to kind of work behind the scenes and work on an individual level, and that can make perfect sense for people. Imposter syndrome is always an effect. When I first got involved in advocacy, I knew absolutely nothing, and that made me not want to do it because I felt like there was plenty of other people out there who knew a lot more than me, and I sounded silly, and it was so obvious that I didn't know what I was doing. But I'll kind of get into that story in a little bit. But it's the first step to getting good at something is to be really bad at something first, right? So and if lastly, it forces us to step out of our comfort zone. We have kind of gotten to the point in our careers, I'm guessing, where a lot of us we know our niche. We are comfortable with our niche. We don't always want to be pressing and pushing our comfort barriers again. So we kind of talked about a lot of this already. So why should you get involved? If you're not there, there's this old adage that I say often, and I kind of hate it, but it's if you're not at the table, you're on the menu. And it's true. If we ourselves are not the ones who are getting involved with making these national policy decisions or state level policy decisions, somebody else is going to be making these decisions. I don't want to continue to harp on the scope creep issue, but one of the reasons why a lot of states have allowed for independent practice of nurse practitioners and PAs is because they were at the table. And up until that point, organizations like the American Medical Association weren't staunchly trying to stop that. And so the people who were at the table got to make those decisions essentially to simplify it. It becomes a state of mind. Eventually, if you do this enough, you start to understand it a lot better, and it can weed out that imposter syndrome where you feel like you don't really have a good grasp on. There's a lot of technical jargon when it comes to healthcare policy, and I understand that more than anybody because I still feel that all the time that there's plenty of stuff you don't understand. But the more time you do this, and the more time you spend learning it, just a little bit by a little bit over time, it snowballs, and you start to kind of get the grasp of it a little bit more. So we're the future of our organization, right? We are the people that are going to be leading the ACR and national policy bodies in the future. Maybe not us specifically, unless you want to, but people who are in our generation are going to be. And our generation doesn't necessarily want the same things that the future generations are going to want, or the generations that are influencing decisions right now want. There was a case recently in the Supreme Court where they were talking about technological policy, and people on the Supreme Court or the justices of the Supreme Court, somebody made a joke about how maybe a bunch of people in their 60s and 70s aren't necessarily the best ones to be making national policy decisions about technology that they can't understand because it's just, too new for them. And that really is true for radiology. A lot of people who may be influencing these national policy decisions don't have the greatest grasp on what's relevant to the practice of radiology right now. Um, we kind of touched up on this a little bit, but the last thing I want to mention is when it comes to advocacy, I think one of the reasons that a lot of people don't get involved in this, or maybe not don't know a ton about it at first, is because it's not really taught as a non-interpretive skill, but it really should be. Ideally, it would be taught as part of the core exam for residents teaching this, like how to get involved in advocacy. But if you think of it that way, it's vital to your practice because it is a non-interpretive skill. Learning how to advocate, even if it's just on a personal advocacy level, or if you want to go all the way up to a national policy level, learning how to advocate can be a really important non-interpretive skill to the practice. So, just to give a little background on how I kind of got started to show you that you can really get started at any point in your career. So, in med school, I was part of the AMA and I went to a couple meetings, but I, again, had no idea what was really going on. I didn't understand it. And then during our 1 year of residency, I went to the ACR meeting with a couple friends. And I just happened to stay for the Capitol Hill Day, where you go and you meet with your representatives or your senators or their staff, and you discuss the most pressing or pertinent issues that the ACR wants you to talk about. And that kind of got me hooked. I realized that it was making an actual change. We saw some policy decisions that were made out of that, where the congressperson wrote us afterwards and says, "Hey, I didn't really know a lot about this policy before you guys came in and talked about it. I changed the way I was going to vote on it directly because of what you talked about or the research that you were to show me." So from there, I got involved with the ACR and eventually it led to where I am now, and then helping to develop this advocacy curriculum for the ACR. So say you want to get involved in advocacy, but you don't really know where to start. This is the part of the presentation where I'll show you that there's a ton of different ways, and not one of these ways is the best way to go. You can kind of pick and choose. If you just want to, start with this, find out who your state representatives are or your state senators are, find out who your US congresspersons are or your national senators are. This is a perfect way to start. So if you scan these QR codes, it'll take you right to the New York State Assembly website or the US government website, if you don't know who your representatives or senators are. You should definitely, if you're not already a member of the Medical Society of the State of New York, you should definitely join that. The Medical Society works similar to how, or most medical societies work similar to how the AMA works, in the sense that the AMA, the American Medical Association, they're the influences, or I guess I should say, the groups that influence the AMA are decided by how many members they have from each respective specialty. So the more ACR members that are AMA members, the more influence radiology has as a whole. So definitely join the medical society. It kind of works the same way. If you're not already a member, join the American College of Radiology, even just to stay up to date on these things. And then I would hope most people here are members of the New York State Radiological Society. The one of the main focuses of the Radiology Advocacy Network is to send out calls to action. So what this is whenever there is a important policy that is either up for debate in the House or the Senate, or a policy that needs co-sponsors, or a policy that the ACR does not support and doesn't want to pass, they will send out a call to action. And what that is it's just an email to you. It usually looks something like this, and it takes quite literally 2 seconds to do this. So you open up your email, it says send letter to legislator. If you click that button, it'll just automatically send a letter to your legislator, and that's it. It takes 2 seconds. Or if you click the preview and edit button, it'll take you to this screen. This is one that we sent out earlier in the year, where it'll tell you who it's sending it to. So mine was Jerry Nandler was my representative, and then I can either just send it as it is, how it's written there, or I can edit it as I want to and say whatever I want to, make it a little bit more personalized. They truly do make this as easy as possible for you. If you don't want to send an email, you'd rather call somebody on the phone. I don't know many people in our generation that would do that, but they have that option as well. So it'll even give you talking points. It'll give you their phone number. It'll give you these talking points so you can kind of go through and discuss it and almost essentially have a meeting with this person. So those are some of the most important and impactful things that you can do that take essentially no time and no effort if you just want to dip your foot into it. And it serves as a really good way to learn more about each issue that is important to the ACR or the state society or whatever it may be. The American College of Radiology is currently developing a advocacy curriculum with the goal of teaching more people about how to be an advocate. And there are a plethora of topics coming out. So the ones that are there's a few that are currently featured on the website, and I can provide you the link to the website if you want, or you could just Google the ACR advocacy curriculum. These are just a few of the topics that are out there right now. So how to speak to a legislator, how to give an elevator pitch, what is advocacy, why does it matter? Probably a lot of the similar topics that we talk about here. But there's a ton of topics that are going to be coming out soon. Everything from, leadership, how to advocate for yourself, how to have good oral communication and presentation skills, practice branding, how to be a good resident advocate, how to run a campaign if you're into that, how to take your bill and get it passed. So there's a ton of really good information on there, and this is going to be a very, very robust curriculum that Priscilla Slanes is leading. Obviously, I'm going to pitch being a member of the Radiology Advocacy Network. What the Radiology Advocacy Network essentially is it's a grassroots community of people who want to advance the advocacy initiatives of the ACR. That's about it. But how does that practically apply? Well, it's whenever a call to action gets sent out to you, you make sure that your personal network or your practice or your friends in radiology, anything like that, or if you're a resident, your residency program, or if you're a medical student, the people in your medical school that are interested in radiology, you just make sure that this call to action gets distributed to people so that they can respond to it as well. You can if you're a YPS member or an RFS member, you can actually serve as a representative for your specific program or your institution to ensure that you're getting all the communication that you should be getting in order to convey this information. There is the radiology ad or the political action committee of the American College of Radiology, RADPAC, which I mentioned earlier. So it's bipartisan. They support multiple candidates per year. And if you're not familiar with what a political action committee is they essentially collect money and then they distribute the money to candidates who are running for national office. So people running for the Senate or people running for a position in the House of Representatives. So it focuses on candidates that are or have support for radiology or have demonstrated support for radiology in the past or who say they would support radiology initiatives. So um, I think in the 2024 national election, it contributed to over 70 House campaigns, 10 Senate campaigns. It generally has a very, very high, I think over 95% rate of getting that person elected. So if it contributes to somebody's campaign, generally that person does get elected. They distributed over $1.8 million to those campaigns in 2024. It's usually among the top physician packs, although over the past couple of years it's been slipping. I think we were all the way down to sixth this year. Usually we're right around number two. The anesthesiologists are really hard to beat because they raise a lot of money. But obviously the goal of RadPac is to get back up there so that we can distribute more money and have more political voice in Washington that way. So I didn't know what these terms meant before. So just in case you ever hear these thrown around. So hard money contributions are money that you yourself contribute to the PAC that they can then distribute to a candidate directly to help fund their campaign. A soft money contribution is something like your group decides to donate a bunch of money to the PAC, and they can't actually distribute that money to the candidate themselves, but they can use that for things like going or hosting a grand rounds or bringing a candidate to an institution to speak or attending uh, the DNC or the RNC in order to, chum it up with the people running at those things. So uh, both are obviously very important, but you as an individual, it's obviously a little bit more important to just contribute what you can to RadPac. So just the structure of it. So RadPac and the RAN both influence Congress and Senate. They do it in a little bit different ways. RAN uses our voice. He uses the collective power that we all have when we act together. And then RadPac uses the money that we donate to the PAC in order to give to them. So it's both the voice and the money that's influencing them. So I know a lot of us like have a lot of student loans. We live in a high cost of living state, which is only getting more expensive. It's really not easy always to contribute money, but I swear even $5 helps RadPac, and they'll tell you that all the time. It doesn't matter what you contribute. It's just important that you do contribute as well. There's members of Congress who have gotten elected with donation help only from individuals who don't take money from PACs or anything at all. So it just shows the power that small individual contributions can really have. Attending ACR is really important. There's a lot of sessions always at the ACR meeting that deal with personal branding and personal improvement and getting involved in advocacy. There's a lot of sessions that deal with YPS specific issues. So the ones that are highlighted here were all sessions that were geared towards YPS specifically. So even if you just want to learn more about advocacy, we pretty much always have a YPS session at the ACR meeting every year on advocacy. In line with attending the ACR meeting, attending the Capitol Hill Day. So this is the event that I was talking about. It's great. They make it very, very easy to participate. Usually you go as a group, so you're never going to be solo talking to somebody if you don't want to be. But you generally go as a group. Usually you have four, five, six people, meet with the senator, meet with the representative, or meet with their staff. And you just kind of go through the sheet that the ACR provides to you that says, hey, these are the issues that we want to talk about. These are some talking points. These are some possible questions they may ask you. Here's the information you can leave them. They make it as helpful and as simple as possible for you. And like I said, these can actually make a difference. We've gotten a lot of feedback from people on the Hill that say, hey, this specific meeting that I had with you was very influential in determining how I was going to vote on this specific policy proposal. If you're somebody that's on Twitter or X or Blue Sky, definitely follow some of these accounts. The RAN is always posting stuff about different policy initiatives, different advocacy issues. Right now, there's some really good accounts that they'll link to as well, just so you can get a better understanding. The more, like I said before, it's kind of a snowball effect. The more you see this stuff, the more comfortable you're going to get with it. The Radiology Advocacy Network has their own website. It's combined with RadPack, and there's a lot of really good information. So that screenshot that I showed earlier, where you can click on individual states and see which issues are up for debate or up for sponsorship in individual states, that's where this is. If you go to the website and you click on RAN by state, it'll bring up this map, and you can click around and find out some good information. There's also plenty of information there for things like site visits. If you want one of your representatives or your senators to come and visit your site, there's a way to help set that up on there. There's ACR staffers that you can contact through the website who will come and give a presentation at your institution, whether it be for residents or it be for your practice, just to teach a little bit more about advocacy and how they can get involved, or even if you just want to talk about what issues are going on in your practice or your community or the state itself. And then you'll be able to, we're kind of revamping the website right now, but you'll also be able to go see all the previous calls to action, see what the result of those were, how many people responded to it, what effect it had when we responded, and things like that. There's a lot of really good advocacy information on this website. Ted Burns, who is the chief lobbyist for and kind of the head of RadPack, he hosts a podcast. Usually there's an episode per month or so, but he's had some really great guests on in the past. It's great. It just kind of talks about advocacy in general, and then it can dive into specific issues based on whoever is the guest of the week. But these are just some former guests that he's had on it. And if you wanted to listen to these things, this will take you right to it, or you could just, like I say, Google Radvocacy podcast. The Advocacy and Action e-news is something that generally gets sent out once a week or so. I think it gets sent out on Saturdays usually. But it just has a bunch of links to what's going on in advocacy and radiology at the moment. The ACR government relations staff puts that together. There's some Radvocacy webinars that take place, and sometimes through the RLI, there's these as well. But previous topics have been stuff like introduction to government advocacy. It's basically what I'm trying to show with this is there's a lot of different ways that you can get little bits of information to help you understand or get involved with this stuff a little bit better. For those of you that work with residents, there's something called the Rutherford Levanti Government Relations Fellowship, which they can apply to. It's generally in their third or fourth year of residency. It's a 1 week program where they spend the week in DC with our government relations team, and they will meet with congresspersons. They'll meet with senators. They'll get a lot better working knowledge of what it takes to advocate to these people on a national level. So it's a really, really, really great program that I would highly recommend if you work with residents to tell them about. And then lastly, there is the Radvocate Leader Certificate. So this is also featured on the Radvocacy website. It's through the RAN, but it's basically a compilation of different things that you do, and you get points for doing these things. Um, you know, little things like attending an ACR meeting, going to Capitol Hill Day, watching a webinar, and it just kind of compiles them all for you so that it creates a rubric or a soft rubric essentially, so that you can get better involved in advocacy and learn a little bit more about it. And if you complete it, you get featured on the website, and then we usually do an announcement at the ACR meeting as well. So that is pretty much the gist of the first half of this talk. There is another half to this talk that actually goes into how to actually advocate in practice. meeting with a legislator, presenting at a committee hearings, things like that. But maybe we can do that at a different time. So the things I just want to reiterate, you're the future of this field. As young physicians, we are the people that are going to be making these decisions and having an influence on national policy, state policy, local policy for years to come. These if issues affect all of this. We can either be influential and actually have an impact on this, or we can just watch the change happen. But the change is going to happen no matter what. And then you are way more influential than you think. You know more than you think. When if you were to meet with a congressperson or a senator or a local government person, or even just talk to a patient or a family member about this stuff, you know more than they do about this. Even if it doesn't feel like you do, you truly do. You are the expert on this, even with what knowledge you have. There's a ton of different ways to get involved. Hopefully, this talk showed you that you can pick and choose. You can do one. You can do multiple. But really, just getting started is the best thing to do. If you have any questions at all about this, you want to get involved in any way, you don't know where to start still after this, please, please, please reach out to me, to any of the ACR government relations staff. They're always happy to talk about this stuff, plug in. There's a volunteer section on the ACR website where you can go and see if there are any positions available if you want to get involved that way. There's a ton of different ways to get involved, and I really hope that each of you can show that if we band together and we raise our voice, we can make lasting policy change happen in this country. So that's all I got.
Thanks, Alex. So this is Angela Tong, one of was a prior YPS leader. And yeah, that's great. I think you know, I agree with a lot of things that you said, that it seems like something very difficult to get started. It's like something out there that we don't really hear much of during training, but it's hugely important, especially with all the legislation and determination of how we get paid, and our protecting our practice, et cetera. So thanks for the introduction to this topic. And I didn't know about all those ways to get involved. So hopefully people reach out to you if they're interested. So thanks a lot.
Yeah.
And we look forward to the second part of this talk. So maybe we'll get that scheduled on the books soon.
Yeah, definitely. And please do reach out if you have any questions at all about it.
Thanks, everyone. Have a good night.